Welcome to another episode of the PFC Podcast. The opinions you hear are ours and doesn't necessarily reflect anyone else's. Now on to the podcast.
My name is Jabin. I'm an internal medicine physician with the United States Army. Through my training and experience, I've had the challenge of taking care of many septic patients, some in an austere environment. I hope to share some of my knowledge and experience on this subject in the context of lessons I've learned while caring for those challenging patients. The agenda for this podcast will be to help provide information that will allow you to decide if you're caring for a sick patient that needs more of your resources and medical attention, or can the patient be safely returned to duty with less support. Treating a patient with septic shock is challenging, but more straightforward in the sense of what interventions are needed in the acute setting. So we will discuss some of the factors that can be used to help clarify the approach to the patient not currently in septic shock, but still sick. We'll also discuss some of the management and care that septic patients will need and how to adjust this level of care as the patient responds or does not respond to your therapy. Ultimately, the goal will be to translate this information into care that can be provided in the field. Let's start with the clinical case. Your setting is a remote area of Africa, and you are called regarding a patient that is a 30-year-old male. He has been lethargic for about 1.5 days, and his coworkers in the area state that he has been acting like he's been drunk lately. He did not seek medical attention, and his colleagues did not alert anyone until he lost control of his bowels and seemed confused while standing and talking to his coworkers. At this time, they alerted the available medic. He was noted to be confused, significant alterations in his cognitive ability. He was febrile. He had rapid breathing and a rapid heart rate. We'll talk a little bit more about this case later, but first, there are many podcasts out there that discuss the definition of sepsis and the clinical criteria for its diagnosis. I'll spend a brief amount of time talking about some of the criteria that you can use to label the diagnosis. But if this is an unclear subject for you, it would be valuable to review the topic a little bit further. Most of this talk will focus on applying some of the definitions and how applying them can help you to your ultimate goal of managing sepsis in the austere environment. A simple way to view sepsis is an infection that causes end-organ dysfunction. There are a high rate of mortality reported at about 10 to 40%, even in the best clinical scenarios, with access to modern hospitals and critical care physicians. One way to approach this topic is to think of your patient on a spectrum, with not sick on one side and death on the other. The challenge will be deciding how far along the axis your patient is and how rapidly is their condition changing. If your intervention is not working and the condition worsens, the patient can progress along the spectrum and become more challenging to treat. Some current thoughts on sepsis are leaning away from defining sepsis in stages. In the austere environment, defining the degree of sepsis will help you develop your care plan. There's a lot of debate on this subject, and there are several tools that you can use to assist in making this judgment call. In medicine, if there are multiple tools and calculators to attempt to address a topic, it usually means that there's not one good answer. So let's talk about ways to identify sick patients and how the available tools and calculators can be used to augment your clinical judgment. Start with, is the patient sick or not sick? Which side of the line do they fall on? Some ways to do this is to look at the patient and get a first impression of their clinical condition. Vitals are easily obtained and a good way to start to answer this question. If labs are available, they can be utilized to help shape the clinical picture. A combination of labs and vitals have been used to define sepsis and construct algorithms to help identify patients that might have increased risk of mortality. We try to use these tools to assist in the judgment call, and we will talk about some of them in the next few slides. If you're deployed with a soldier and know them well, the battle buddy says he just doesn't look well, don't hesitate to continue your evaluation with your clinical concerns despite normal vitals at the time of you examine your patient. Using vitals and labs, we can decide if the patient meets SIRS criteria. SIRS stands for Systemic Inflammatory Response Syndrome and is defined two or more of the following criteria: temperature greater than 100.4 degrees Fahrenheit or less than 96.8 degrees Fahrenheit, a heart rate greater than 90 beats per minute, respirations greater than 20 a minute, a low PaCO2 of less than 32, a leukocyte count greater than 12,000 or less than 4,000, or if there's band cells with greater than 10%. Without the ability to obtain a leukocyte count, it is possible to miss the diagnosis of SIRS in a patient if only one of the other criteria is present. However, when asking yourself if the patient is sick and you're finding one or more of the above criteria, you should have increased suspicion of the presence of an illness that could progress to sepsis or septic shock. SIRS is often, but not always, present in sick patients, and keep in mind that it can also be present in healthy patients, so use it to augment your clinical evaluation. If you establish that the patient appears to be sick, you support your clinical suspicion by taking vitals, and the vitals indicate that SIRS is present, or despite SIRS not being present, the patient still appears ill. Your next step should be to evaluate for possible infection. In the austere environment, without full lab capability, you might find yourself diagnosing sepsis with just the suspicion of an infection and not a confirmed source. So when should you suspect infection? A good history and physical is your greatest tool. Ask specific questions and listen to the patient. As discussed earlier, if the patient appears ill, this can be enough to pursue a diagnosis of infection with nothing else. Start with the common sources and go from there. Septic shock presents when the patient is hypotensive with end-organ perfusion deficits, despite volume resuscitation, that requires vasopressors to maintain a mean arterial pressure, or MAP, greater than 65. Sepsis 3 is one definition that defines septic shock using the above, and also incorporates serum lactate greater than 2 in the absence of hypovolemia as part of the criteria. Because infection plays such a critical role in therapy, let's take a quick tangent and talk about some of the common sites of infection that you should consider investigating. CNS infections are usually associated with neurologic signs and symptoms: nuchal rigidity, photophobia, headache. Any suspected CNS infection should be treated aggressively and will likely require IV antibiotics and a higher level of care. Systemic infections from ocular sources are likely the result of significant damage to the globe of the eye and will need care provided by a specialist. Superficial eye infections like pink eye or conjunctivitis will cause minimal systemic symptoms, if any. And in adults, ear infections are usually very limited and will present as ear fullness, ache, decreased hearing, possible some drainage. A unique infection risk includes the triangle of danger. It's located from the bridge of the nose to the corners of the mouth. Shaving trauma, abrasions, nose picking could all be sources of superficial infection in the region. And these infections can drain through vascular channels, resulting in a spread of the infection to the cavernous sinus of the brain. Treating a viral infection with antibiotics can cause more harm than good. So follow care guidelines for antimicrobial use. Mucus color and characteristics are not reliable means to determine if the infection is viral or bacteria. Patients will often be mildly ill, but tolerating necessary activities. Symptoms include congestion, rhinorrhea, cough, sore throat. And a viral URI can precede a bacterial URI or even pneumonia. Monitor and follow up with these patients while they're in your AO. Supportive care is usually all they need. Pulmonary illnesses can be challenging to treat and might require intubation. Some concerns will include aspiration pneumonitis versus aspiration pneumonia. If your patient experienced trauma, they required intubation, or any other reason had an alteration in their level of consciousness that prevented them from protecting their airway, aspiration is always a risk. Pneumonia can occur as an infectious process on its own or from introducing organisms into the lower airway through intubation or instruments. A patient that was previously healthy could have a common pneumonia seen in patient populations, or could have an infection more common to your specific area. Be familiar with the common causes of pneumonia in the general population as well as your AO-specific tropical diseases. If you suspect pneumonia, perform a good H&P with careful auscultation for increased breath sounds. Try and take a chest x-ray. If the chest x-ray is not available, use tactile phragmatists to assist in the diagnosis. Remember that while examining the lungs, you can place your hands over the lung fields, and if you sense decreased transmission of vibration felt while the patient is speaking, that this can support the diagnosis of pneumonia. The dense inflamed lung tissue does not conduct vibrations as well as the healthy tissue. There are many foodborne gastrointestinal illnesses that result in nausea, vomiting, and diarrhea. Most are self-limiting, and avoidance of foodborne illness is the best measure. You do this by eating only from reliable food sources when possible. Sick contacts are another source of GI symptoms and are often caused by virus. Again, these are usually self-limited. UTI can be from introduction of an organism into the urethra and the bladder and can advance up the ureters to the kidney. Suspect pyelonephritis when the patient has had UTI symptoms and presents with flank pain. Tapping the patient's costophrenic angle and looking for pain response is an easy way to examine the kidneys. Any abrasion, burn, or puncture of the skin can be a source of infection. Many of our patient population test positive for MRSA, and this should be factored into your care plan and affect what antibiotics you stock and dispense. Common skin injuries include equipment rubbing and causing blisters or abrasions. Oftentimes, equipment is dirty from contact with the environment, and the patient might have had limited access to hygiene while the skin surface is being exposed to trauma. Bug bites or exposures to plants that cause pruritic reaction can lead to secondary infection if the patient scratches often and causes skin injury. Skin infections can be very superficial with erythema and possibly purulent material. Cellulitis will appear as a red erythematous area extending from the site of origin. The border is demarcated but can appear to fade into the non-erythematous skin. Mark the border with a marker at the best guess of the leading edge and write the date and time, and then you can trend the progression to determine if the therapy is efficacious or if the condition is worsening. A deeper infection that involves fascial planes and lymphatics is erysipelas. This infection usually is very well demarcated, and the skin can appear tough and thickened, like an orange peel. A collection of infection that is firm and soft. There are signs of possible abscess and are more common and should raise your suspicion for MRSA infections. If you suspect infection and you have a difficult time identifying the source, always consider tubes, lines, and drains in your workup. Like trauma and instrumentation, these items can be sources for infection. The fact that these are often left in place and are indwelling, they can increase the risk of bacteria in the environment or skin surfaces becoming the source of the infection. However, do not assume that just because there's a line in place that it is the source. An example would be labeling the IV line as the source of an infection when pneumonia is the actual cause of the sepsis. Look for purulence, erythema, and pain at the sites of the lines. Tubes and drains can show signs of infection at the insertion site similar to lines, but they can also harbor infections in deeper structures like UTI from a Foley catheter placement or intrathoracic infection from a chest tube placement. Bacteremia is the result of bacteria entering the bloodstream. Common causes are procedures like IVs, but can also be from an abscess or other source of infection that spreads into the vasculature. HIV often presents as viral illness or sore throat initially, and later can present as opportunistic infections. Tropical diseases have a vast array of presentations, and you should work to be familiar with the common diseases that will be in your specific area. It will likely be too difficult to learn all of the diseases in all of the regions of the world, but study and make cheat sheets for significant diseases that you might encounter. All trauma will increase the risk of infection. Skin and mucosal surfaces act to keep environmental bacteria out of the body and to keep bacteria that is supposed to be in and on the body in their respective and appropriate places. When these barriers are broken down from abrasion, burn, or penetrating trauma, sepsis can rapidly develop. Penetrating trauma into the abdomen can cause gram-positive organisms on the surface of the skin to enter into the abdomen. This mechanism of injury can also cause direct damage to the bowel or cause enough blood loss that results in bowel ischemia that can cause the gram-negative and anaerobic organisms that make up the normal GI flora to be a source of infection. The projectile that caused the trauma can also have bacteria present on it and result in inoculation of organisms into the patient. Instrumentation also falls into this category. If the patient has undergone any procedures and is currently healing from the procedure, this could be a source of infection and should be considered. Performing the procedures in a sterile controlled environment reduces the risk, and that is why hospitals use operating theaters that have controlled access. In the deployed setting and in the field, less than optimal conditions are the rule, more so than the exception. So getting back to the clinical case, when the patient arrived to the aid station, he was very sick. He appeared sick. His vitals were 96/60, blood pressure, heart rate of 122, temperature of 101 degrees Fahrenheit, and respiratory rate of 26. His vitals met CIRS criteria, and we suspected an infection and confirmed it with a rapid malaria test. The patient met the definition of sepsis. But how sick was he? There are actually criteria and scoring schemes that we can use to help identify illness severity. Some require more data and labs, while others require simple evaluation of the patient at the bedside. Remember that all of these tools are used to augment your clinical judgment, not to replace it. The QSOFA score is a bedside prompt that may identify patients with suspected infection who are at greater risk for a poor outcome outside of the intensive care unit. It uses 3 criteria, assigning 1 point for low blood pressure, high respiratory rate, or altered mentation. Note this requires no laboratory equipment for the evaluation, and a score of 2 or more points is associated with a greater risk of mortality. PRECEP, or the Pre-Hospital Early Sepsis Detection Score, utilizes part of the SIRS criteria, which we discussed earlier. It adds oxygen saturation and blood pressure while removing the lab component of white blood cell count. An elevated temp will give 4 points. A low temperature gives 1 point. Elevation in heart rate is assigned 2 points, as well as low oxygen saturation and a low systolic blood pressure. Rapid breathing is assigned 1 point. A score of greater than or equal to 4 suggests sepsis. But how do we treat septic patients will depend on how far along the spectrum these patients are. The core treatment plan for sepsis includes identifying the cause of the infection, possibly gaining control of the infection by performing an incision and drainage, or I&D, or removing the infected lines or other source of infection. Antibiotics should be given early and must cover the suspected organism that is causing the sepsis. If a source cannot be determined and bacterial source is suspected, use a broad-spectrum antibiotic. Improvement in vitals and symptoms should be seen in the first 24 hours. If not improving clinically, the first step would be to broaden the spectrum of antimicrobials and continue to evaluate for a source. IV fluids should be crystalloids. Use normal saline, LR, or isolite. Avoid colloids. And blood products are not recommended for sepsis management. Remember that sepsis is a vascular leak problem, and it's not a hypovolemia problem related to blood loss. A number to shoot for your IV fluids is about 30 milliliters per kilogram given over the first 3 hours. The intent of the IV fluid administration is to maintain a mean arterial pressure greater than 65 and a urine output of at least half a milliliter per kilogram per hour. The urine output per hour is an average over time, and it should be evaluated very frequently. Telemedicine consults should be utilized early. In the hospital, a team of providers see the patient. If they get admitted to the ICU, they will be followed by a critical care physician, possibly a nephrologist, an infectious disease specialist, respiratory therapist, nurse, pharmacist, and possibly more. While in the austere environment, the patient might require all of these services, while you're the only provider and you're not fully trained in these specialties. The solution is telemedicine, and making telemedicine consults early is always a good idea. Austere environment considerations for a sick patient. Antipyretics can improve the patient's symptoms, but can blunt physiologic response. This could be an early indicator of worsening condition, and it might be worth considering holding these agents for the patient in the first 12 to 24 hours. If you determine that there is an infection present and they have greater than 2 SIRS criteria, the patient is septic by definition, and antibiotics would be indicated if you suspect a bacterial source. If the patient is tolerating PO and oral intake, it is possible to treat with oral antibiotics and monitor for 24 hours for a response. Plan for close follow-up, either in person or over communications if the patient can be returned to duty. Treat early to prevent progression. And an example of this would be if you see a slowing of urine output, you should address this issue before it falls below the minimum level of the half a milliliter per kilogram per hour. Austere environment considerations for the very sick patient. If this patient is in your immediate area but not held at your aid station, you should develop a plan for monitoring the patient's urine output, their cognition, their vital signs, or any pertinent available labs that you can get. This could mean that you go to them every couple hours, or you have them check in before meals, as long as there's a schedule that's kind of set up for the patient to follow. This all kind of depends on how ill the patient appears. If you start with frequent checks and decide that the patient appears stable, you can increase the interval, or if the patient appears to be worsening, you can shorten the interval of times between checking on them. It might seem that all patients with sepsis should be evacuated or held right at your aid station. but you yourself have probably had an infection with fever and tachycardia, but still performed your duties while being septic. A patient in this category should be monitored closely, utilize scoring systems to determine severity, engage telemedicine early, and reevaluate frequently for changing the condition. One early indicator for progression of disease is lactate. A lactate greater than 2 can indicate sepsis physiology that occurs at a cellular level and precedes any changes in the vital signs. Occasionally, patients diagnosed with sepsis have normal lactate levels, so use this in conjunction with your clinical picture. If you have the ability to monitor lactate, it can also be used to direct your therapy. You can give IV fluids and perform interventions with a goal of normalizing the lactate level over time. There are point-of-care lactate monitors that are battery-operated, field-hardy, and lightweight. Could consider using these in a far-forward environment with no other lab capabilities. You also want to monitor and trend vitals and use these trends over time to change your care plan as needed. Use the available scoring tools to estimate the severity of the patient's condition. Another consideration is gaining IV access early. This can be a simple move that is nearly impossible while the patient is crashing. An IV site can be bandaged to protect it while the patient performs light duties and goes about their business. Even an IO obtained with relative speed isn't as fast as an IV already in place. Be sure to protect the site and use hygiene practices that reduce the risk of IV site-related infections. Treating the very sick and dying in the austere setting. The key element to this is the further to the right on the spectrum, the more difficult it is to treat the patient and move them back to the left. Preventing progression of sepsis to septic shock is far easier than reversing septic shock. Treat early to prevent progression. You'll want vascular access early to administer IV fluids and antibiotics. You're going to continue to monitor and trend the patient data. Give IV fluid boluses as indicated. Use an anticipatory care plan. Pre-calculate medications, pre-stage airway equipment. Your greatest resource is your medical knowledge in this situation. So take advantage of addressing these issues when you're fresh and not in an emergency situation. Prepare and set resources aside so that you know where they're at and you can get to them quickly. If you have medically trained team members that can help discuss if-then care scenarios and anticipate roles in the event of an emergency. If you're the only medical provider, identify assistants that can contribute to care and discuss roles in the event that you will need immediate assistance and have little time to react or explain. If you have limited IV fluids, plan to use them early. Exhausting your supply of IV fluids early versus saving them for a crashing patient is kind of a tricky balance. Use your IV fluids if you need to improve perfusion and reverse the effects of end organ dysfunction that is associated with hypoperfusion. Saving your last bag of crystalloids until the patient is in septic shock will just make treating shock even more difficult. Prevention is always better than trying to treat. If the patient can tolerate PO, maximize oral intake to maintain intravascular volume, and develop a tentative care plan for evacuation or try to evacuate the patient to a higher level of care. The austere care plan for septic shock is driven by the fact that patients at this stage are medical emergencies. Apply the ABCs or the CABs of BLS. Gain control of the patient's airway if indicated, and utilize the ARDS-NET protocol for lung protective ventilation. Provide bolus IV fluid and prepare to initiate vasopressor therapy. By definition of septic shock, the patient has already been bolused and did not respond. How much should you bolus the patient before saying the patient has not responded? This is another area of debate in medicine, and there's many devices and techniques used to estimate this. One way to approach it is you have rapidly infused 1 liter of crystalloids and are on your last half of the second liter, and the patient is still hypotensive with continued end organ dysfunction. Plan to initiate vasopressor therapy while you continue to bolus the patient. In the ICU, the preferred therapy for septic shock is norepinephrine or Levophed. Packing epinephrine is more tactically oriented as it has multiple medical uses beyond septic shock. Become familiar with the administration plan for epinephrine in this setting. The next slide will discuss this. Continue to monitor vitals, trend patient data, and the appropriate antibiotics that will be used will probably require IV antibiotics. This is secondary to the decreased blood flow to the GI mucosa and possible decreased bioavailability of PO antibiotics. Telemedicine consult should be initiated as soon as possible when the patient is stabilized or efforts to stabilize are not effective. If you're continuing to resuscitate the patient, have someone initiate the consult for you and pass information to them so that they can assist. Remember to use caution if the patient transmitting the information to the telemedicine consult is not a medical person. Have them tell the consultant that they are not medically versed, and secondary to the patient being critical, the only medical provider is providing patient care. In this situation, use simple terms and have your assistant write things down as clearly as possible. If available, monitor urine output with a Foley catheter. If you have labs available, use labs to monitor renal function. Decreased urine output and increased BUN and serum creatinine indicate hypoperfusion injury to the kidney. This likely indicates an acute decrease in glomerular filtration rate, or GFR, which is going to indicate that there's decrease in kidney function. If you're monitoring labs, serum creatinine lags behind the true kidney function. This means that the drop in the kidney function is actually worse than what the labs are reflecting at the time of the acute injury. If decrease in GFR is expected based on labs or urine output, consider reducing renally cleared medications or use renal dosing for a GFR less than 20%, which should be available for the medications that you carry. A patient treated for septic shock will consume a lot of resources and medical manpower, so when possible, evacuate the patient to a higher level of care. This is an epinephrine drip cheat sheet constructed by Dennis. Become familiar with this setup, the dosing and the titration. You can see, looking at it, it's kind of complex with a lot of numbers and considerations, and anticipating your need for epinephrine, pre-calculating the doses and setting up the equipment will save time and reduce error if the patient is very sick and begins to crash. Consider printing this slide or designing a sheet of your own to use as a quick reference so that it's easy to get to. After arriving at the aid station and determining the patient was very ill, an IV was started and the first bolus of normal saline was hung. Labs were analyzed, and he was noted to have a lactate of 12 and a pH of 7. He had a decrease in his blood pressure and continued worsening of his mental status. The first bag of normal saline was pressure infused, and preparations for the second liter were started. Norepinephrine was prepared, and a central line was placed at the right subclavian. Prior to administration of the second bag of crystalloids, the patient became unresponsive with an absent pulse. Telemetry showed a cardiac tracing in PEA arrest. Compressions were started, and epinephrine was administered per ACLS protocol. For the patient that is in septic shock and actively crashing, treatment is BLS oriented. But what about the patient that is not at that level of distress yet? How do you initiate a therapy and then adjust that therapy over time as the patient's condition improves or worsens? The first step is to decide where the patient is on the spectrum and what does the patient need for the treatment. The next step will be to initiate the therapy addressing the most critical needs first. Some corrective actions will be expected to respond more rapidly than others. If you have an acute drop in your mean arterial pressure and you bolus IV fluids, you should expect a relatively rapid improvement, or you move to the next intervention of repeating your bolus or possibly starting pressors if it's indicated. Antibiotics will take at least 12 to 24 hours to show efficacy. If you have not seen an improvement, or worse, the patient's condition declines over this time frame, if possible, try to broaden the spectrum of your coverage of your antimicrobials. Most septic shock admissions are monitored with multiple labs and likely an invasive device to estimate stroke volume variance or cardiac output. Often, an invasive arterial pressure reading is utilized for continuous blood pressure monitoring. Commonly, ultrasound is used to visualize the inferior vena cava to estimate volume status. If these are available to you, utilize them to the best of your ability. Continuous monitoring with telemetry tracing, cycled blood pressures, and pulse oximetry is always nice to have. If you have this capability, but you're running low on battery supply, use it intermittently or at times that you're initiating or changing therapies, like starting pressors or changing your dose. Ideally, like in the ICU setting, you'd have an arterial line with constant invasive blood pressure tracing and recordings while administering the pressor. Use your non-invasive measurements with frequent cycles to plot trends, and plotting the trends, use this to guide your therapy over time. Renal labs include electrolytes and GFR calculation. If you have these labs, remember again that the labs will lag behind the true value or the true function of the kidney. Without labs, you can utilize urine output. Remember that it should be about 0.5 milliliter per kilogram per hour. Giving diuretics does not improve the GFR and does not improve the clinical outcome. So avoid using diuretics and just give more fluids if the patient's not putting out enough urine. If trending the white blood cell count is not an option, replace this with following fever curve and plotting it over time. A single elevation in temperature means less than if you look at your Q1 hour temperature trend. Stroke volume variation and cardiac output are being used to determine if the patient needs more IV fluids. One way to determine if the patient's hypotension would respond to volume infusion is to perform a straight leg raise test. Simply take a blood pressure with the patient supine and level. Now have someone hold both of the patient's legs above the level of the rest of the body. The idea is that the venous blood pooled in the lower extremities will be returned to the central vasculature, and if the heart rate and blood pressure improves, this would support the idea that the patient would benefit from more volume and continued IV fluid infusions and boluses would be indicated. Coming back to the clinical case, after about 40 minutes of attempted resuscitation with CPR, airway management and epinephrine, there's no return of spontaneous circulation, and the patient was pronounced dead. Earlier interventions could have improved the patient's chance of survival. Not recognizing he was sick and him not seeking treatment, and the continued movement along that spectrum until his condition became irreversible made it very difficult to treat this patient, and he ultimately had a bad outcome. To summarize, the diagnosis of who is sick and who is very sick progressing towards death can be a challenge. Deciding the best care plan at the initial patient interaction can also provide quite a significant challenge. There are multiple diagnostic criteria and scoring systems, but no one system is best and no one system has all the answers. Remember, they're used to augment your clinical judgment. The foundation of therapy is source control of the infection, appropriate antibiotics or antimicrobials, treating hypoperfusion with crystalloid therapy, and if not responding to IV fluids, initiating vasopressor therapy to maintain your mean arterial pressure greater than 65. Telemedicine should be a part of your care plan and utilize it early. Treat the patient early to prevent progression of the disease. And if the patient is not responding or the patient is exceeding your resource capabilities, evacuate the patient early to get them to a higher level of care. Hopefully this information will provide some assistance to you and your team the next time that you're caring for a septic patient in a remote area with limited resources. And I thank you for listening.
That's another one for the books. Now take the challenge and go to the website www.prolongfieldcare.org and answer the questions linked to the podcast. Test your knowledge on the scenario and keep an eye out for the roundtable talk where we answer the questions and find out what an expert would do in the exact same scenario. I'm Dennis with the Prolonged Field Care Podcast. Out.